joined by 3 colleagues from UHBW today. We've got Stefania Fertingo, who is a consultant paediatric infectious diseases We've got Sue Wade, who's a consultant antimicrobial pharmacist, and Raji Dillian, who's a consultant microbiologist. And this is a bit of a whistle-stop tour for antimicrobial stewardship and a few areas that we've been working on recently, and a couple of new thoughts for going forward. But please, at the end, ask questions on whatever is your top priorities at the moment. So I was just going to start with a bit of background to antimicrobial stewardship, which hopefully, if my slide moves on. There we go. So I'm sure we're all aware of this, that AMR is still a problem, and is a problem internationally as well as locally. This slide just shows the global deaths of 2019. It shows the numbers that are attributed to AMR and comparing that to other frequent causes of death, just to highlight that it is still an issue despite the work we put in so far. And then when we look into the UK data, this is the number of deaths in 2019, and you can see those involving bacterial infection are as high as those around ischemic heart disease, with those then associated with AMR or attributed to AMR, so the red or the black at the top, are as high as Alzheimer's and other dementias. So we think about the work we put into ischemic heart disease and cancers and things, and the fact that AMR is just as important, and that we need to be working on these areas. And then we look at bacteremia and resistant bacteremias, and there's been a national plan to reduce the numbers of bacteremias and to reduce the numbers that are resistant. And this is local data, recent data 23, and it was only reported last week, but it shows that we've had no change in the number of bacteremias since 2019, despite all the work we've done. And actually, we've had an increase in resistant bacteremias. And this has been a new national action plan that came out recently, which has said we need to keep them at the level they are and try not to let those increase further. So despite the work we've done, we still need to continue our work into antimicrobial stewardship to support antimicrobial resistance. This, I'm sure we're all aware, but it's always good to have the reminder that actually we haven't had new classes of antibiotics in the last 30 years, which is now actually pushing towards the 40-year mark. And we're all aware that actually as soon as we introduce new antibiotics, we start to get resistance. So the importance is to keep antibiotics working and to enable the ones we've got to continue to be useful. So how are we united in the UK at prescribing compared to the rest of Europe? And actually, we're a bit sort of mid-table as far as the number of antibiotics we prescribe. And although we have been reducing our prescribing amounts, we still can go further. We know there's a high correlation between antibiotic use and resistance. This graph is looking at outpatient use of penicillins versus the non-susceptibility of Escherichia to penicillins. And you can see that really clear link between that, which is why that just trying to reduce the antibiotic prescribing in primary care with those sorts of infections like ear infections and sore throats, where we don't always need antibiotics, is really important still. So the total consumption of antibiotics, this is England data, and it is all antibiotic consumption, so it includes hospital and everywhere else, shows that we had a peak of consumption in 2014, which then reduced down in 2019, seeing that low use during the COVID-19 pandemic, but the last couple of years is going back up to really pre-pandemic levels. And then in primary care, this is primary care consumption in England, shows again that high rate in 2014, reducing 2019. And then the last 2 years, we've just sort of topping up slightly over where we were in 2019. A lot of that slight increase will be due to that group A strep outbreak that occurred the winter 22-23. So it's going to be really interesting to see where we level off in 24, which is probably our first true year of prescribing, really. And just to make sure we're not starting to creep up with our antibiotic prescriber, we can keep it down at the 2019 levels. As we're all aware, most prescribing happens in general practice. Other community settings are starting to increase slightly, and interesting dental practices has gone down slightly in this latest graph from last year's data. but otherwise it's generally pretty stable with general practice taking the majority of antibiotic prescribing. And this, I hope you've seen before, but this is our prescribing within BNSSG. And we can break this down to practices if you want to see your prescribing. You can see that increase in 22, 23 from the group A strep. And what's nice to see then is this last year, we've really gone back to the normal pattern of that slight increase in the winter and slight decrease in the summer of antibiotic prescribing. So it's also back to pre-COVID rates, it feels like. We get set targets for antimicrobial stewardship, which we have shared with practices many a time. And there are two targets. First of all is antibiotic prescribing per star PU. And you see those three horizontal lines. We have gradually been targeted to reduce our prescribing over the years. There was a national target for a 25% reduction of antibiotic prescribing in primary care between 2019 and 24. We also are targeted on the proportion of broad spectrum antibiotics for which we have coamoxiclav, cephalosporins and quinolones. And again, we're targeted for that to be below 10%. BNSSG is that dot highlighted in red. That's compared with the other ICBs, sub-ICBs with nationally. And you can see we are benchmarking really nicely on both of those, and one of a handful of ICBs, and until recently, the only one in the Southwest, which was benchmarking for both targets. So thank you. That's all due to the work that's been done out in practice, and it is noted nationally that we are doing well. And what I have done last week is sent out data to each practice with your current prescribing rates, just so you can compare and so you know where you are. For prescribing. But just to say, we do have a bit of variation. This is PCN level. I am denied about what level to share this data, but I thought PCN is probably appropriate. And you can see we have got variation between practices and PCNs. The lines aren't that helpful, but just to say, with broad spectrums, every PCN is meeting that 10% target. We do have the odd practice that isn't, and for antibiotics per star PU, we do have a couple of areas which are above still, but generally most are meeting the target. And finally, just to remind you about the target leaflets. I really like the target leaflets. I don't think we promoted them much locally, but I would still encourage practices to look at them. They were actually updated last week, so the latest versions are available on the Target website. And they're in multi-languages. They're different formats, so you can share them in different ways with patients. But they just look a bit more modern than they used to, and they're just useful tools for encouraging non-antibiotic use where appropriate. Okay, I'm going to pass you over to Stefania, who's going to do a little whistle-top tour through prescribing in children.
Hello, thank you very much. I'm working at the Bristol Children's Hospital, and so apologies if sometimes this feels a bit secondary carey. But I echo what Liz just said. The UK, this is for pediatric prescribing. He's not the worst, but definitely not the best in Europe, and there is space for improvement. Next slides. So it is possible to prescribe less in children, and the children are amongst the age groups most that mostly receive antibiotics. About 50% of children under 4 would have received an antibiotic in England, so it's quite a lot. And there is a worry generally about treating children, or actually not treating children, that mortality is linked to reducing the use of antibiotics. And these slides just show you that the death in under 5 is not actually linked to the rate of prescribing of antibiotics. We've seen that Estonia was the country in Europe with the lowest prescribing, and it has also amongst the ones with the lowest mortality in under 5, and this is maintained in the under 19th. And Greece, that was the biggest prescriber, is actually having higher mortality. And it's quite shocking to see that UK is probably the worst country in Europe. But this is kind of a little bit of another story. It's not linked to antibiotic prescribing. What has made it possible for doctors not needing to prescribe so much antibiotics in children is really the very successful history of vaccinations. And you can see here from the 90s, the vaccines that target bacterial infections have started to come into the population. And in 92 we had Hib, and then meningitis C, then the pneumococcus with more and more serotypes, and there is the pneumococcal 20 that is now in quite advanced study, and then the meningococcal B and ACWY, and this vaccination have completely eradicated these diseases from what we see in clinic. So if you look at the next slides, for each vaccination, you have a very, very successful curve that shows you that before the vaccination, you see a lot of the disease, and then the disease disappears almost completely. And often you have a little bit of a bump with a few more cases, and those are generally ironed out by changing the schedule of the vaccines. And this is what we've seen also with Men-C, with pneumococcus. The pneumococcus is slightly different because we have more serotypes of pneumococcus, so it doesn't disappear completely. But still, we see a lot less disease than before. And that's why we don't really need to prescribe so much in children. A majority of children will come to hospital with viral infections, and actually the rate of bacteremia in hospital is about 0.1 per 100, so less than 1% of children that come to hospital have a positive blood culture. So next. Prescribing children varies, as Liz was saying before. This is England, and you can see that this is the variation of prescribing, very similar to the whole population in the country, and BNSSG is the best one on the left. And you can see that, however, there is still some work to do, because there is variation in the prescribing in different practices. It'll be very interesting to kind of dig in and understand a little bit more why this is the case. But often it would be very much possible for the highest prescribers to reduce their prescribing. That's not impossible. Often doctors feel that the reason why they prescribe is that parents are really pushy, they really want antibiotics, they often had antibiotics in the past, and there is an expectation. And actually, there's been a lot of work done in Bristol University, in Oxford, etc., looking at leaflets and ways of communicating with parents. And a bit like the Target website, there are very good website for children's as well. Also, the Healthier Together has a lot of leaflets that you can actually SMS to the parents straight away with very useful information. So often it's a matter of really educating at every consultation the families about the good and the bad of the antibiotics and why actually antibiotics are not necessary. There is one thing that often is forgotten, that although antibiotics are safe, there are a lot of side effects linked to it, and also a lot of drug errors. And in fact, in general practice, the highest risk of drug errors is on antibiotic prescribing in children, because of the volume of antibiotics that are prescribed, not because they are particularly difficult to prescribe, it's just that there are so many prescribed. Yep. This is just another leaflet. As I say, this is a very nice booklet. There is also the Handy app that is very useful for health professionals and also for families to kind of keep on the phone and consult if there are problems. And one of the messages of all of these leaflets is that actually symptoms do last quite a long time, and that's normal. And so parents do need a lot of reassurance and education about that.
Lovely, thanks, Stefania. I'm just going to now turn to touch on the prescribing incentive scheme from last year and just show you a few results and outputs from that scheme. So we had 2 projects last year. Most practices looked at 5-day amoxicillin prescribing. There's been a general push towards shorter is better antibiotic prescribing for many infections, including upper respiratory tract infections and lower respiratory tract infections, really where the lowest course length that's clinically appropriate reduces the risk of AMR, reduces side effects, increases compliance. So this is our BNSSG data over the last couple of years. And as you can see, we've had a real shift over to 5-day prescribing. That's purpley red line is our 5 days compared with our 7 days in blue. And you can see that swap over and that increase. So that's really good. And then in fact, we've become the highest 5-day prescribing of amoxicillin nationally in the last couple of months, which is lovely. And what is also really pleasing is that we've continued that trend in that 5-day prescribing after the end of the incentive scheme. So the prescribing's continued. Just to say, we've had great involvement from all the PCNs, and the bottom graph shows the percentage change that's occurred, and you can see that every PCN has shown that increase in 5-day prescribing. I'm not wanting to pick out particular PCNs, but just to note that Stokes, which looks a lot lower, was much higher with their percentage at the start of the year, which is why their change is lower. But you can see that every PCN is up there and seeing that increase in 5-day amoxicillin. So we focused on amoxicillin because it's quite an easy antibiotic to target, because all of the NICE guidelines for respiratory tract infections recommend 5 days. There isn't much else where you wouldn't give 5 days, with the odd exception, but generally it's 5 days prescribing. We can also look at other antibiotics and see that increase. So for this, I pulled out doxycycline and Pen-V, and you can see that the legacy of doing the amoxicillin is that we're also seeing that 5 days for Pen-V and doxycycline. Obviously, you do get some other exceptions, but for the majority of patients, 5 days is appropriate for those. The other project that every practice did was the acne project, where we were highlighting the new NICE acne guidelines and reviewing patients on long-term antibiotics for acne. In the course of the project, 890 antibiotic prescriptions reviewed, and 41% of those which were stopped, which is great. It was I've definitely felt that some practices probably had better benefit from the project than others, but I think in all practices it highlighted the NICE guidelines and also showed that change in practice for reviewing acne patients. And of note, 2 patients have been on antibiotics for more than 10 years and had them stopped. So there's definitely some individual benefits that occurred from this review. You can see from this graph that over 24 weeks is in purple, and we've had a slight reduction in limocycline being given for more than 24 weeks for patients on it for that long term, but not huge numbers. I'm now going to pass you over to Sue to talk about penicillin allergy.
Thanks, Liz. I'm Sue Wade. I'm consultant antimicrobial pharmacist in UHBW, so in the BRI. Next slide, please. So penicillin allergy, it's something we get very excited about because it means we can't use so many antibiotics. And I know it's clearly difficult when you're faced with a patient who reports a penicillin allergy, but it's something we're really going to try and we've certainly been focusing on in acute care, and we'd kind of like to spread the love into general practice as well. So it's a bit of a watch this space. Penicillin allergy, 10% of the population report a penicillin allergy, but only 10% of those have a true allergy. And we certainly find when we look at our records, it's a huge number. We looked at them about 4 or 5 years ago. We had in just UH Bristol, so this before we merged with Western, we had 19,000 patients reporting a drug allergy, and almost half of those said it was a penicillin allergy, so around about 9,000 patients. 2% said anaphylaxis, 19% said something else. It wasn't anaphylaxis, but a whopping 79%, we didn't know what it was. It just said penicillin allergy with no details, and this is where we run into problems. So individuals labelled as penicillin allergic are more likely to prescribe broad spectrum antibiotics, have longer hospital stays, have an increased risk of acquiring MRSA, C. diff, or VRE, vancomycin-resistant enterococci. They've got an increased mortality and an increased risk of surgical site infections. And there are, obviously, because of all these things, significant implications for the cost of healthcare. They're more likely to need antibiotics, and they're more likely to develop resistance. So we're on a hiding to nothing when we consider if we wrongly label someone with a penicillin allergy. It's difficult, we know that, and really what we've been considering is we're going to collectively do some work with Liz and my colleague at MBT to see if we can come up with some easier ways to get these labels right in the first place. And we've done it at the moment, we're thinking about it in a sort of a traffic light way. So if they're red, we label as penicillin allergic if it's an immediate reaction, or if they have a severe delayed hypersensitivity reaction. So we need to include things like Stevens-Johnson syndrome or toxic epidermal necrosis. Those patients with other pro-inflammatory health conditions who report a penicillin allergy, I think they're more likely to have a severe reaction, so we can run into difficulties there. These patients we would label as penicillin allergic. We need to get this quite clear. We know that the symptoms might involve a skin rash, urticarial skin rash, angioedema, shortness of breath, wheezing, anaphylaxis, etc. The patients we come across who report a genuine penicillin allergy, no, they can tell you they were severely unwell. They might have been hospitalized, or an ambulance might have been called, or they generally have a very good recall of it. It then becomes more difficult as we move away from these patients. I appreciate that. Next slide, please. Green, again, nice and easy, not penicillin allergic. And this is where the patients start to get confused. These are normally side effects of penicillins or intolerances. Nausea, abdo pain, diarrhea, all the usual GI upset stuff, headache. Lots of patients will say I'm allergic, and when you quiz them a little bit more, they say I get thrush, not understanding that it's not an allergy. These patients are not allergic. The other classic is history in a family member. My mother was allergic, so therefore I must be allergic as well. Not true. So we need to educate the patients and let them know they are not allergic to penicillins. These are the normal side effects of most any antibiotic, and we need to make sure they understand that. Next slide, please. And here we've got the difficult box. So the amber ones in between the green and the red. These are the mild maculopapular or urticarial rashes. These effects normally occur more than an hour after the dose, and usually in the patients without other pro-inflammatory health problems. I appreciate these are tricky, but there's a lot of evidence to say that these people can be given a penicillin. So if a child is given a penicillin, again, a small number, between 4 and 7%, will have a repeat mild benign rash, but a whopping 95% will have no rash or other symptoms. And lots of kids get rashes that are related to the infection, often viral. We know this, it does become difficult. Ideally, we would give them a single dose oral challenge, and we've started doing oral challenges for some of our inpatients in the hospital. Certainly we've introduced a protocol within our ICU, our general ICU, in patients where we can get enough information out of them or out of the family if we think it'd be of benefit, and most of the time it is, because most of them need antibiotics, to use a penicillin. Then if we can get consent, then we will give them a single dose trial. But we've also done it in patients outside of ICU as well. We give them an oral challenge. We give them a small sort of adult patients, we give them a child-sized dose, 10% of the normal dose. We observe them for 20 minutes and then we give them a full dose, and we observe for an hour. Interestingly, the patients I've spoken to where we've done it are really quite keen to find out if they are genuinely allergic to penicillin, because most of them fit into this category, and they don't know if they are genuinely. They think they are. Someone said they are back in ancient history. And they really want to know because they have lots of courses of antibiotics and often our choices are limited. We are, as I said, I'm working with Liz and my colleague at NBT. We're hoping that we can start to pull together. There's so much information out there now. Some really good leaflets that obviously we will make sure are approved by all 3 organisations, but leaflets for patients so we can begin to explain to them and at least investigate whether or not they have a genuine allergy, if at all possible. But we need to get patients understanding and saying the right things. We need to celebrate the fact that they might not have a penicillin allergy, because it does open up so many opportunities for treatment. Next slide, please. What we really need, and what we really struggle with, and it is by no means perfect within the acute trust. What we need to all be doing is making sure we've got an absolute minimum amount of data when recording an allergy. And what the minimum data we need is the date the allergic reaction occurred, exactly what the drug was, and the type and the severity of reaction. Because often we're faced with, and appreciate that systems don't make it easy to do this, but often we're faced with it just says penicillin on somebody's drug history record, which just leaves us in a very difficult place if we've no further information. But yeah, as I say, that's the minimum data set we'd really like. There's a lot of work going on across BNSSG around allergies, and if we can get those things right at the beginning, it puts us in a better place. Next slide, please.
Thank you, Sue. Now, Rajay is just going to talk about fluoroquinolones.
Great, yeah, thanks, guys. So yeah, my name's Rajay. I'm one of the microbiology consultants in UHBW and stewardship lead at BRI. So I thought I'd do a few slides just touching on the use of quinolones in primary and secondary care, just in light of the newish MHRA alerts that have come through. So next slide. So I think obviously it's quite important to obviously still understand that fluoroquinolones are very good broad spectrum agents. And I guess the ones that we routinely use both in secondary and primary care are ciprofloxacin. I don't think levofloxacin's on that slide, but again, another very good quinolone, which very much similar in terms of activity to Cipro, but probably a bit better gram-positive cover and loses a little bit more gram-negative cover compared to Cipro. And also moxifloxacin as well, which is, we don't usually use it. It's just kind of a later generation quinolone, but another one that we have up our sleeves if we are in desperate need to use an oral agent. So yeah, as I was saying, it's important, obviously, with these new alerts to kind of think that it's still quite a good broad spectrum agent to use in treating patients, especially in secondary care where they're on IV therapy. We can get them off IV antibiotics, and that in another kind of aspect kind of improves patient care from that side of things. Next slide, please. So obviously with the MHRA kind of history over the last, I think, 10 to 14 years, there has been an increase in reports of mainly musculoskeletal adverse effects using quinolones, kind of brushing with all quinolone use, not just ciprofloxacin. And I think only recently, in the last few years, there's going to be some mental health aspects as well, which they've now kind of nailed down a bit more as well. And obviously these can be reversible, but there is a very small population or small proportion of patients, I think 0.001%, that will have permanent disability from side effects with fluoroquinolones, which we need to take into quite important consideration. Next slide, please. So just looking through the previous, the history with these alerts, so I think it's kind of a culmination ending up with kind of this year where quinolones are now going to be antibiotics of more or less last resort, given the side effect profile. Well, we can only prescribe them really if there's no other alternative options, whether it's in the kind of clinical best interest of the patient, and where, you know, there's, in terms of first-line antibiotics that have been tried in primary or secondary care and they've not worked essentially, and we still don't have kind of microbiological samples or sensitivity results to suggest using another agent, which, you know, it does kind of reduce, I guess, the broad spectrum use of quinolones, but as I say, they are pretty good antibiotics to use in terms of their activity, so it's not something that we need to take lightly, to be honest. So next slide. And I think the use in the BNSSG has come down, and looking at these graphs, it does suggest that the kind of prescribing of quinolones in primary practice has kind of reduced over the last 5 to 6 years, and especially, you know, kind of using a lot of Cipro and ofloxacin, I guess, in primary care. I think looking at those graphs, the ofloxacin and the levo kind of usage has kind of basically plateaued, but there has been a reduction in the usage of ciprofloxacin. And I guess this is probably in light as well of the MHRA kind of alerts coming through over those past few years have obviously highlighted people to being a bit more cautious in quinolone use. Next slide. So I guess the kind of target when it comes to quinolones now in primary care is to kind of ascertain the areas where we are using it empirically. And I guess the empirical guidance is based on epidemiological data to suggest that other agents orally aren't as effective, and it's going to be a careful consideration of weighing up those kind of benefits and risks. And in some certain situations listed there, they are still the first line treatment for certain infective conditions, which you'll see in primary care, such as prostatitis, I guess epididymoorchitis as well. And certainly in terms of specialty colleagues as well, in terms of the hematology prophylaxis, they use quinolones quite a lot. It's on our guidance for SPP prophylaxis, just based on the rates of resistance to other agents, to suggest that Cipro is your best clinical antibiotic efficacious agent. And obviously the pseudomonal infective exacerbations of bronchiectasis. So, you know, Cipro and quinolones are the only oral agents you can use for these cohort of patients. So you're kind of stuck really. You can't really use anything else orally for those sorts of patients. And if they're failing on those, you're looking at more IV therapy, unfortunately, for those populations. So I guess in terms of primary practice, it's obviously just trying to review all those kind of instances where you're looking at empirically prescribing quinolones in the first place, and just seeing where we can help in terms of ongoing management and counselling of patients that are going to be on it for a period of time. Next slide, please. Yeah. Oh, sorry, SVP stands for spontaneous bacterial peritonitis. So usually should be under the gastroenterologists as an outpatient in terms of follow-up. So they ideally should be following up these patients if they're on SVP prophylaxis for, you know, the foreseeable future. And obviously, if a quinolone is prescribed, then, you know, there's very good leaflets that are out there that MHRA are published that you'll need to go through with the patients in terms of the musculoskeletal side of things, and also the suicidal and mental health issues as well related to quinolones have just come in over the past few years. And obviously, it's very important to let kind of family members and other people close to the patient know that they're on these agents, just to be aware of the side effects too. So it is quite a lot of work if patients are going to be put onto quinolones in primary care in terms of monitoring these adverse effects. Next slide. Thanks. So I think obviously this is also prompted a review in primary care to look at, to see if the patients that are on long-term quinolones and see where we can minimize these, because obviously if they're on it for weeks and months, then the chances are developing these adverse effects are increased. Tricky in terms of bronchiectasis. I think the other kind of cohort of patients I've not mentioned, even though they're going to be a small number, are the ENT patients that have got necrotizing otitis externa. You've got prosthetic joint infections in hips as well. You've got the CF population where quinolones are used quite extensively. So these obviously patients will be under specialty care, and hopefully will be getting followed up by the specialty teams as well in terms of keeping an eye out for any effects of using quinolones. But it's obviously working together with these specialty teams and obviously involving ourselves in microbiology as well if there's any queries or concerns that you need us to help you out with. Ciprofloxacin for catheter change, I thought it was IM gentamicin, but I could be wrong. But yeah, if there's no symptoms or signs of a catheter-related infection, if I've got no history of it, then you don't really need antibiotic coverage for a catheter change. But yeah, SBP prophylaxis will be another one that they'll potentially be on long-term quinolones for. So, but hopefully the gastro team will be helping with follow-up regarding that as well. And next slide. Oh, that's the end of it. Thank you.
Thanks, Rajay. We have purposely left a lot of time for questions today. So really now's your opportunity with a good broad range of people to be able to answer. Shall I start by picking up some of the queries that have come up in the chat? But actually, if people want to raise their hands as well, they're very welcome to. Let's go with what people have put their hands up for first. I'll stop sharing so people can see. And Laura, would you like to?
One of the hardest things we find to deal with is when people say, oh yes, they were labelled pen allergic when they're a kid and you're seeing them now at 70. Have you got, and then it limits your use, have you got a good strategy to deal with that? When you know it's probably not a pen allergy, but then we don't feel safe in the community to do anything different.
Yeah, in exactly the same boat. And we have done where we have used penicillins where we think there's a low risk, or we've used cephalosporins where we think there's a very low risk. In those elderly patients, especially, the penicillins way back when were much sort of dirtier compounds, I believe. So I think a lot of the issues and the side effects, if you like, were from not quite such purified, for want of a better phrase, drugs. Do we have a strategy? If we have to treat them here, we have on occasion, certainly where we've had to put someone on long-term penicillins we've had sort of endocarditis patients, and where we'd much rather use a penicillin long-term than, say, a quinolone. We have done an oral challenge in some elderly patients when we think they're very low risk. I appreciate that it's difficult. It's almost impossible to do it in primary care.
About from now on sorting out the coding right. It's hard to do anything retrospective, isn't it?
Yeah, so, it is absolutely. Cephalosporins are often a good alternative if you've got that sort of doubt, I think. We used to think the crossover was up to about 10% of patients being allergic to cephalosporins that have say they've got a penicillin allergy, but I think it's way lower than that, and that's always a possibility if you think it's a really low risk. It is difficult. Okay, I know. We're chipping away at it.
I think my other point was about antibiotics in children is obviously we try and follow the guidelines, but often then if children end up in A&E, they're like, oh, your GP should have given you antibiotics, and we know what the guidelines are and that children's illnesses evolve, and I just didn't know whether Liz or the infectious disease team could do a bit more work with the kind of A&E departments about their messaging about, oh, the GP should have given you antibiotics, because obviously that is the case occasionally, but actually often that's not the case. And yet then, as you say, that then sets us up for the future that, you should have given them to us in the first place. So yeah, I'm sure I'm not the only person who's had that.
Yeah, and that I think we can add is not helpful, is it, to have messaging like that? So it's we can definitely, Stefania, you might want to come in as well.
Yeah, we do education with the ED, and there is definitely a lot of willingness to change, and we are working on reducing prescribing there and improving prescribing. As you say, children's evolve fairly quickly, and sometimes it happens that they deteriorate and they come here, and often they get prescribed antibiotics in ED, and if they are admitted, they are stopped the day after. So there is a lot of really stewardship on the wards as well, to try and kind of cut this in the bud. Because often, the children are admitted because they deteriorated, but often it's just because of a viral infection. They need oxygen, not antibiotics. These are really hard message to pass. And I'll talk to the colleagues in ED and try to make sure that this doesn't happen. It's never good. And for the penicillin allergy delabeling in children, again, it's a piece of work we are doing. Unfortunately, we don't have a lot of capacity. So our allergy clinics have incredibly long waiting lists, but we are doing our stewardship, and we identify children that are penicillin allergic and try to refer them. Unfortunately, they sometimes have to wait 2 years to get the challenge.
Can I just come on with the penicillin allergy piece? This is very much about, to start with, just making people aware and getting that label right when people are diagnosed going forward, as we said, and making sure it's clearly documented. I think the next thing we need to think about is how we can start to delabel people in primary care, and it's a bit of a watch this space. Let's start getting the messages out, making sure when secondary care delabel people that is being transferred into patients' records in primary care, so the whole system knows the patient's been delabeled. I think Sue's had examples of where they've been delabeled and then it hasn't got into the records, and therefore the patient is still thinking they're penicillin allergic, or the records are thinking, and they go back into another trust and they don't get a penicillin again. So we just need to make sure that sort of that joined up thinking and joined up awareness to start with. Then we can possibly start looking at the low hanging fruit, the patients who aren't actually allergic at all. It is these amber patients that are particularly difficult. The red patients, if it's unclear, then they can be referred into the immunology team. But the amber patients are the sort of, there's no capacity at the moment in the system. This is very much work in progress, but we thought we wanted to start talking about it to get people aware of the work that's occurring and aware of where we may be headed with it. But we're perfectly aware that you can't give an oral challenge in primary care. There's not the infrastructure at the moment to be able to do that. Jenny.
Yeah, thanks. Just to on that point, is there a cohort of patients who would have a sort of amber mild delayed reaction, perhaps an urticarial reaction, and then further exposure to penicillin? Is there a risk that they would go on to develop a type 1 hypersensitivity reaction to it, or does that not really happen?
It can, from my understanding. And this is the risk that we're taking when we give them an oral challenge, I guess. Anyone going to wade in on this one?
The number is really, really low, at least in pediatrics. There's quite a lot of centres that do these regularly in London, and actually Weston-super-Mare does it in their outpatient, open access daycare. And is really, 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 really low.
Okay.
But it's not impossible, and that's why they need an oral challenge.
And I think that's the nervousness in primary care often, is if you've had a cutaneous reaction, in a child, that the risk of giving them and sending them off into the community doesn't sit very comfortably. So I think that's where the kind of, it's very difficult, isn't it?
Yeah, no, you need to observe them, and you have to have the facility to deal with an anaphylaxis. Because that's the safe thing to do.
Yeah, absolutely. Okay, thank you.
As Liz said, it's really, we're just trying to get our messages the same across the entire patch, because as we've delabeled people and the label falls off, or the delabel falls off, should I say, and it's the information we've got when they're coming in, which is often sort of scant, or and probably because people used to have paper medical notes and now it's all become electronic, and it's just making sure that the flow of information is the same.
I think there's probably a bit of work to be done within EMIS, the system that we use, because sometimes if you just write an adverse reaction, whatever that might be, whether it be vomiting or diarrhea or whatever, to a medicine, it does sort of save it as an alert in there. And so that like you say, unless you very clearly documented, it just kind of, that then sticks, I think, doesn't it?
Yeah, it's not good. We've been having allergy discussions with lots of people across the patch, and the systems we're using, really don't help us at all.
No,
but the more detail we can get, the better, to be honest. But I appreciate it's time consuming and tricky to put that in somewhere, isn't it? Yeah.
And again, I think it's really important to educate. What you might call allergy. If he's vomiting, you have to be very careful to say to the patient, this is not an allergy.
Absolutely. So even if you document as, I think I'm trying to remember what but there is a bit where it says adverse reaction, and I think that's almost saved in the kind of allergy bit, on their home screen. I'll have to double check that actually, but so it's just about educating and how we document it within their consultation record, I think, and how the coding is saved.
We are.
Go on. Sorry, carry on.
I was going to say, there is some work going on. There is an allergy working group within the system to try and work out some of these difficulties. We are obviously constrained by what EMIS can do. And interestingly, there isn't even a delabeling code for if you delabel an allergy. There's not a code to say they've been delabeled at the moment, but there's a request that's gone in nationally for that. So I think we are quite constrained by what we have. But as Sue says, it's that conversation that patients have and their understanding of what their allergy is, and actually they may be suitable for delabeling in the future, or actually they are properly allergic and you really should never have an antibiotic if you're in that sort of red group. So it's just making sure that patients don't hold on to that label, I think, and don't consider it as being a special thing for those where it's not.
Somebody's asked, if a patient is delabeled, how is the information shared with us? Is it in discharge summary? Might this get missed? We are encouraging anyone to put it in the actions for GP or medicines changed or those sorts of boxes, so that gets picked up, because I know we have in the past sent out a specific letter and that's got missed. And I know Liz was referring to, we had a couple of patients who had allergies to ticaplanin identified by the allergy clinic, having had anaphylaxis on the operating table. A letter went out, and we could see the letter sat on the system, but the records still showed that they had an allergy to penicillin. This is how the patients get things completely muddled up. They know they've got an allergy to something, but they can't remember what. But the letters, it's tricky. They don't seem to get action. So at the moment, I think the best place is for us to put it in our action for GPs, or in the drugs changed, etc. boxes on a discharge summary, and then it's immediately visible.
We've had a couple of queries about quinolones. Jonathan, you stated about bacterial prostatitis and whether we need to look at the guidelines and whether that's chronic prostatitis rather than acute, so we can look at that, and I might be in contact. I'm actually in the middle of reviewing all our antibiotic guidelines at the moment, the big massive ones. So if anyone has any comments of things that you think is being missed or changes you would think would be useful within the guidelines, it would be really helpful if you got in contact with me. It's a bit of a long process having a good look at the whole guideline. We obviously change things when things come up, like new NICE guidelines, but every 2 to 3 years I have a look through the whole thing to make sure we haven't missed any changes and everything's up to date. So if there are any comments about the guidelines or anything that you think needs altering, please do shout. We want to make them as clear as possible for everybody.
The NICE guidelines for prostatitis, when they're up for review, I can't remember when they were last done. Need to look into that.
I think they've just reviewed them in light with the Cipro, the quinolones, and have kept Cipro as the option.
Yeah.
And then there's also a query from Rachel: how delayed are tendon side effects thought to be? Is there evidence they can happen a year later, for example?
I'm just looking at Medicines Complete.
I think they can. I think even after stopping, they can after months and years, unfortunately. But yeah, it's a tricky situation, to be honest, because they are, and especially with the penicillin allergy alternatives, sometimes Cipro is the only thing, or quinolones are the only things you can use. So yeah, it's a tricky one, and it'll just need a kind of multi discussion with infection specialists, specialty teams, and primary care if there are ongoing concerns about it. Can't see any way around it, unfortunately.
Jenny, would you like to come in?
Sorry, just one further question, just maybe around nitrofurantoin prescribing, because I know there was a move for that to be first line for UTIs, and then the new MHRA guidance around the risk of the hepatic and pulmonary risks has obviously made everyone really nervous. And we had a significant event at our practice whereby a patient developed pulmonary fibrosis after a relatively short course of nitro, and so it's obviously made everyone very, very nervous. Is there going to be any change, do you think, to the first line UTI prescribing?
Oh, so for the short term, usually 3 days for a woman, course length of for acute UTI, then we would still recommend nitro, sometimes trimethoprim, and actually compared with some ICBs, we haven't gone hard line on the nitro, because for your younger women where you don't have the risk factors for resistance, actually our sensitivities do show that trim is appropriate in those patients. What we would recommend is for long-term nitro, then really thinking about it if you're going to put somebody on prophylaxis, and we do have guidelines about the monitoring we recommend if a patient is started on long-term nitro. It sounds like your patient was short-term though, which thankfully is rare.
I don't think it was very short. I think it was she'd been on prophylaxis for a short period of time rather than it being an acute course. Yeah.
Okay. So I've not. So I think it's very rare to have any side effects like that for acute courses. It is when patients go on to the long-term prophylaxis, and we do have that treatment, and we do have that guideline which does go through the steps of which ways to prescribe antibiotics.
Yeah. Okay. Thanks.
Oh, and of course, methenamine is now licensed, and that is in our guidelines. It's a non-antibiotic option for long-term prophylaxis as well. We've had a couple of queries about pharmacy first, and Jenny, you've stated that you've seen patients who've been refused antibiotics by the GP and then gone to pharmacy first and given something for their sore throats. Hopefully there are rare occurrences, and I guess actually if you do have concerns, it would be worth emailing into the ICB and just letting us know which pharmacists you are concerned about if you think they're not following the guidelines. They do follow exactly the same fever pain, for example, with sore throat and other criteria for giving antibiotics. And payment for them is not based, and for seeing patients is not based on just giving antibiotics. They are not incentivized to give antibiotics at all. What I would say, as probably the same comment that came up earlier, is patients progress. So it may be that they hit different criteria when they enter the pharmacy, but you don't know from the individual cases. What we are about to get is some data, and we're waiting for that nationally to come out next month, where we can start to have a look and see which pharmacies are prescribing lots, which may just be because they're more active, but also if we've got concerns, we can link them up to their local GP practices to see whether the overall prescribing for that area has changed or not. So we will be doing a deep dive into our prescribing. Obviously in the BNSSG, we did have the PGDs before pharmacy first, so there's not a huge step change for a lot of infections, but we will be keeping an eye and looking at that data as soon as it's available. But like I say, if you do have specific concerns about specific pharmacists, do let us know. We can always investigate. And as far as your community pharmacy numbers, whether that's taken into account, it's not currently still GPs. You can see from that the other community was 5%, where GPs was about 74% of prescribing. So still GPs do prescribe the majority of antibiotics. Very small numbers are still relatively at community pharmacies, but we do need to start linking up those numbers so we can look at patient population. And some of the national data is now looking at patient exposure to antibiotics, not just prescribing from a GP practice, so we can look at the numbers of patients who are being exposed to certain antibiotics in some dashboards rather than looking at specific GP prescribing data. So it's just learning how to look at that data and understand it. Anything else? Annabelle. Oh, sorry, Annabelle. I think you had your hand up and then put it down. Jonathan, do you still want to?
Can you hear me?
Yes, thank you. Yes, we can hear you.
Okay, good. So with the pharmacy first as well, I've also found that they've said, yes, we can't prescribe, but you should go to your GP and get antibiotics. And then it's almost that the expectation is set up there. I don't know if anyone else, if that's just the small number again. But yeah, I've definitely had that at times.
So that's useful, and it's probably similar to the A&E. Is that patient expectation, isn't it, when they go to see somewhere else? If for specific reasons, if you think that the pharmacies are misdirecting people, again, do let us know so we can have conversations. But yeah, it's maybe just we need just to get those comms out about the patient's expectations if they're referred somewhere else. So thank you for that. That's useful to know. Jonathan.
Yeah, I thought I'd just, as the urology obsessive, I thought I'd come in as response to the question about D-mannose, furthering my question earlier about prostatitis. Liz and I, we worked on the recurrent UTI guidelines for women on remedy, and D-mannose is in there, but I put in the chat the link to the JAMA paper that was published this year that was co-authored by or led by Alistair Hay in Bristol, which unfortunately was a primary care-based study looking at D-mannose, which showed that they didn't find any benefit from D-mannose for prevention of recurrent UTI. So Hiprex is where the evidence is, unfortunately, because that's prescription only. So Hiprex has got the ALTER trial, which shows good randomized, good RCT evidence of non-inferiority to prophylactic antibiotics for recurrent UTI. But D-mannose, this RCT didn't show benefit. So I've kind of, whilst I don't dissuade people from taking it if they've found a benefit, I've kind of moved away from advising it and stronger move towards Hiprex and vaginal estrogens for postmenopausal women.
Thank you, Jonathan. We've had a query about diverticular flare and if there's any guidelines. So we do have guidelines for diverticulitis in our big chunky guidelines, which is co-amoxiclav. The query is diverticular flare guidelines, if there are any. We have significant numbers of patients requesting co-amoxiclav for flares. Difficult to persuade patients from historical. Thank you. That's definitely something we can take away and look at it. Rhea, sorry, you're the one who put.
Sorry, I was just going to try and explain it. So what we're finding is that uncomplicated diverticular disease, where I wouldn't say they needed antibiotics, but you end up with a systemically well person who goes, well, I always have it for my flares. I need it because every time I go into hospital, they always give it to me. And so you then end up in this very difficult situation when clinically you wouldn't say that they needed just pain relief and there isn't a clinical indication, but the guidelines aren't strong enough in helping support us. And so people will want antibiotics, ironically, for diarrhea because they think that that's a flare, where there's no pain, no temperature, no evidence of infective markers up. And you end up with a lot of, several people having multiple courses of co-amoxiclav over several years for diverticular disease flares, when actually it's probably just can be managed much more conservatively. I just wondered whether there's any way of trying to sort of help guide us more or not?
Yeah, so I'm not quite sure what it says on the primary care guidance for diverticular disease, but certainly you're completely right. If they've just got symptoms and signs that can be controlled by pain relief, that's all they need. So the recurrent use of comoxiclav is obviously not the solution. So yeah, if the primary care guidance on diverticular disease doesn't kind of iron that out as robustly as it should, then I obviously fully advocate trying to change that to make sure it is more robust.
Just sharing that part of the antibiotic guidelines. So it may be, sorry, it's quite small. I can't work out how to make it bigger while under pressure, but yeah, it's yeah, maybe we can have a look at that and make sure we get that bit. Yeah. So thank you for that. We are out of time. Has anyone got any burning last questions before I think we've covered virtually everything in the chat, and if not, we will just go through and make sure we've answered all of those, and we'll put something in the chat afterwards. But if not, thank you everybody for joining us this lunchtime and for your time today. Hope you found it useful. If you have any further questions, do feel free to contact one of us, and we're really happy to answer them. Thank you for your time.
Thanks.
Thank you.
Thank you.